Gentlemen, it's a true privilege to introduce an internationally esteemed Professor Luke Kim, a true pioneer in minimally invasive and navigation-guided and endoscopic spine surgery. Professor Kim serves as a full professor in the Department of Neurosurgery at the Catholic University of Korea's Seoul St. Mary's Hospital. He has over 300 publications. With that, he has profoundly shaped the field of spine surgery. To my opinion, he's the most highly published professor in the field of endoscopic spine surgery. I think there is no one else in the world who has published that many papers regarding endoscopic spine surgery, and also impactful papers. His groundbreaking work includes, besides endoscopy, also cutting-edge robotic and AR guided techniques. As a testament to his academic standing, he holds deputy editor roles in both Neurospine, Journal Neurospine, and Global Spine Journal. These are renowned journals. He has been awarded multiple times, including five times, the Wiltse Award. So Professor Kim began his focus on endoscopic spine surgery back in 2006, so 20 years ago. Despite early skepticism back then, he has driven its growth into a mainstream discipline, which is becoming now a mainstream discipline. In 2018, he chaired the first endoscopic course at the prestigious AO Spine Davos meetings, and today he led the NAS Diploma Curriculum Task Force for Endoscopic Spine Surgery. He has trained multiple international fellows. What distinguishes him isn't just his surgical mastery, but really his thoughtful approaches to medicine. Through his exceptional technical skills, visionary scholarships, and inspirational leadership, Professor Kim is reshaping the future of spine surgery. We are very honored to have Professor Kim, Luke, within us as initiator, co-initiator, and co-founder of the Endospine Academy, which started around 3 years ago. This is it is very important, Luke, that you're into this group, and not only that you're into this group, but really shaped it from day zero. Please join me in welcoming Professor Kim as he shares his experience with us today in, I think, a very entertaining way. Luke.
So can you hear me okay? Yeah. Thank you. It's a great honor to stand in the beautiful arena and Balgrist University Medical Hospital. Yeah. My talk today, I'm going to talk a little bit, the non-academic, but sort of entertaining talk, because only people are spine, others are the other specialty. I don't have to stick in the spine, right? So this is why write down only this in the morning, the next turn of the spine, and offer you can refuse. So this is my disclosure, and real disclosure. Do you know what happened in 1977? Anybody? No? You are coming after 1997, most of them you, right? And 1992 and 2006. So 1977, the first series Star Wars came out, right? Because I loved my daughter and I, a big fan of the Star Wars. 1992, really personal. And when I started the medical school, 1991 and 1992, I have the name of Luke, right? And 2006, like the master spoke, I started my career at the endoscope, 2006, right? So that's why my nickname Luke Spine Walker, not Luke Skywalker, okay? Okay, but sometimes in my every human being has this kind of the mind, the ambiguity, right? So what I mean, this is my wallet. I'm gonna open it. See? Right? So my nickname is Luke Skywalker, but my mind, there's just somewhere in the corner, there's a dark side too, right? So, classification of spine is very simple. From the perspective of the MIS, spine surgery is MIS and non-MIS. And the MIS, we have the microscope and endoscope. This is the nomenclature they published by the AU Spine. I drew these pictures 2019, and it was published 2019. So I highlighted full endoscope and the endoscope assist spine surgery. Currently, we face the full endoscope and the another endoscope surgery bipolar there. This is the comparisons, the unipolar bipolar microscope. But you remember that today's talk is Godfather, family, right? Godfather, everybody knows. The story started in 1945. The story immigrant in the Italian mafia, right? So the story, the Godfather, he had done the classic spine surgery. He was the Godfather of the spine surgery. And then De Vito had thought the MIS would be the future of the spine in his mind. So he wanted to find the son of MIS, the future of the spine surgery as the MIS. So he has 3 sons. The first, Santino, Fredo, Michael. Each guy is a representative of the surgery, open surgery, microscope, and endoscope. Let's look at the open surgery first. The Santino, he has a little bit wild and explosive temper. He was supposed to be Newton because he's the first guy, right? He didn't figure out the future, though. That's the problem. So since he created the wild temper, he created collateral damage, which was unbearable by the family, and his end was inevitable, right? Killed it by his brother-in-law. And let's see the debate between the open versus microscope first. What I want to highlight, so one of my friends working in Sydney, Australia, Ralph Morse, he published a very good design comparison study, published JNS only more than 23 years ago, 2014, 11 years ago. It was the comparison study, classic open versus the tubular microscopic over-the-top decompression. Now, this guy, Ralph Wagner, learned the endoscope from me, and he is a big fan of endoscope already, right? Let's see another debate, open versus endoscope. From the first son's view, endoscope is the baby, newbie, right? What's going on? So this is one of the only randomized control trial between the classic open versus the endoscope. This is my results about that. So let's see the fate of the open surgery. Oh, sorry. Anybody remember? Sadly, he passed away like this manner. Okay, let's move to the second son, microscope. Right? Fredo is the least intelligent and weakest of the colonel's brothers. He rarely gets to participate in his family business. Do you think could he beat his youngest, smartest sibling? What do you think about that? Fredo. Let's see. So everybody knows the microscope is good. I still love the microscope spine surgery. So that has the advantages and challenges a little bit. From the endoscope perspective view, the microscope surgery, where is surgeon's eye over the spine? Surgeon's eye, you can see the surgeon's eye in the microscope eye. Eyes is already far from the patient back, right? So when I describe the advantage of endoscope spine surgery, endoscope is something like the swimming in the pool. What is a pool? That is a spinal canal. Your eyes already get in the spinal canal. You can look around every corner. Your side, the other side. So that is the true important, little bit underestimated, little bit overestimated of microscope versus endoscope. So look at this beautiful case of paraspinal disc, foraminal disc herniation. I love this kind of the microscope tubular approach. I put the 60 millimeter tube under the endoscope control, take out the bone, reach out to the disc herniation, remove it. Very nice. Of course, as you expected, incisions is pretty small. 1 year later, you cannot figure out the skin incisions compared to that of the endoscope. So where is the real value in the endoscope? It's not the skin incision. It's not the simple muscle damage, right? In the 21 years old patient, actually, it's not a big deal between the microtube approach versus endoscope. We're going to find the value is something more than the skin incision and the muscle damage. If you have a little bit more time, I'm gonna talk it later, hopefully next year. And yes, Fredo tried to adopt the change, but what is the change, adoption? That is MED, microscope and microendoscopic discectomy, actually driven by the Medtronic. This is one of the great tools for MIS fusion. But in the field of the endoscope, this MED eventually failed, right? Please make sure, I'm gonna say to MED, please make sure your identity is not the microscope, it's not the full endoscope, right? So let's see the evidence, microscope versus endoscope, especially for lumbar disc herniation. Where is everybody, you respect the high-level evidence, randomized controlled trial, but in my mind, the best evidence, if you have this surgery twice in your life, microscope discectomy versus endoscope discectomy, that patient is the best evidence for which one is the real value, right? I have a couple of cases. Let's see the patient-reported outcome. 33 years, when he came up to me with this kind of problem, so big herniation at the level of 4-5, it was 13 years back, right? You see he was almost the Kaurikina. So I did it, a simple microdiscectomy. You can see the resection of the hemilaminectomy, right? This is post-op MRI and a 1-year MRI too. And the problem is 4 years later, he came again because another problem happened. Look at the MRI, that one, the low level, the same size, huge disc herniation. At the time, I solved this problem, full endoscope transfer endoscope lumbar discectomy, like this manner, okay? And then I asked him,
수술 2번 받으셨잖아요.
I love this kind of asking the patient. You got the surgery twice, endoscope decompression versus open decompression, microscope decompression. So this is the answer, the patient. The final outcome, like the evidence, is similar. The problem is not the problem. I asked him again, if you have another disc herniation, what would you
그리고
get it?
그러면 두 개
Endoscope
수술의
versus
차이점을 좀 얘기해 줄 수
microscope.
있어요?
Patient choice, like you expect, he gonna get the endoscope for sure, right? I also operate his father as well with endoscope,
네, 김영건님.
right? So let's see the quality of evidence. Regarding the high-level evidence, randomized controlled trial excluded something the meta-analysis. Only over the 10 paper have been published. And this is the current, the paper about the randomized controlled trial. Start with the Michael Meyer, 1993. He is the well-known, the legendary doctors, surgeons, in the field of MIS, endoscope versus lateral surgery as well. And the last one is my paper about randomized interlaminar versus the microscope surgery. In my mind, the best quality of the randomized controlled trial, I'm gonna suggest the two one. The first one is the Chinese paper. Professor Li Minlong, the working at Sun Yat-sen University Hospital, Guangzhou, he published this paper. And the first series was published January 2019, and he published, his juniors published a little bit long-term follow-up and the cost effectiveness and others. That is the best paper randomized controlled trial ever so far. Let's see the microscope versus endoscope for lumbar stenosis. So I started the endoscope 2006, but it was 2014 when I started the endoscopic laminectomy, right? And this is another outcome. This patient got a surgery twice. First one, 4-5 right decompression, and a couple of years later, he got a surgery 4-5 left as well.
만족도는 어떠세요?
So I asked him, what about the post-wound pain, post-recovery for daily life, and overall recovery, and final improvement, leg pain, and cost?
95에서
So
99.
he answered me, overall outcomes, I'm gonna give the microscope this
표적인 만족도는 어떠세요?
score, 85,
두 번째로 그러면
endoscope,
100점 중에 몇 점이라고
99.
하실 수 있을까요? 100점
Right.
낮으실 필요는 없어요.
So, of course, 85 is not bad. 90 is good. But how can we reach out to the more than 95? That is possible with the endoscope. That's the message. This is one of my the retrospective cohort study between the versus the microscope, endoscope, microscope versus for spinal stenosis. And what about the cervical spine, the micro versus the endoscope? Still, we have the debate between Frederick and Michael. So look at this case. This 47 years old, middle-aged gentleman. He has a lot of the medical problem, ankylosing spondylitis and rheumatoid arthritis. He had to take on medicines, warfarin, because he had the history of the open heart surgery, valvular replacement. Every single surgery, knee joint and hip joint, he suffered from this kind of issue of bleeding from the side of the operation. And I operated this patient 9 years ago, foraminotomy left side and right side. And a couple of years later, he has another problem, is left side symptoms. So this is right side microscope tube decompression at the 2 level. And the another problem came up with him, left side symptoms, 2017. At the time, I treat this patient with the endoscope and foraminotomy like this in manner. And I got an interview with the patient. So a similar question. What about your post-op pain please compare the microscope and endoscope? And what about post-op improvement and the general satisfaction? So I asked him again, like the other patient, if you have the another surgery, we don't want it anymore, but if it happened, what would you get it? He suddenly answered, my choice endoscopic foraminotomy. So we can say the winner is a full endoscope. So I don't want to blame the microscope tube approach, but we can make it better. That's the message. So this patient has ankylosing spondylitis. It's the endoscopic, microscopic, just decompression cannot be the text-based answer. But decompression works very well over the 8 years. No instability happened, even though the patient has ankylosing spondylitis. So what about the randomized control trial between the microscope versus the endoscope? Look at the face of the two brothers. It changed, right? Michael is not Nibi anymore, right? So one of my ex-fellow from Thailand, Dr. Bit, he published, once he finished the fellowship, 18, he started randomized control trial between the tube surgery and endoscope surgery, right? He published this great article, actually first article versus the full endoscopic versus the microscope tube approach for spinal stenosis. So let's see the fate of Fredo. Everybody recognize already.
Holy Mary, Mother of God, pray for us sinners.
Okay. The most importantly, so surgeon's side, so we actually follow the randomized control trial. But from the governor's healthcare givers, the cost effectiveness is the most important. So that is why I published the first cost effectiveness related to spine. This is the first paper that. So published in the Spine Journal. And that's the current evidence for that. And so we can say, who is the godfather? There's no doubt, endoscopic spine surgery. Also, the Michael, is the most intelligent. He is the youngest. He is the intelligent and powerful son. Yeah, but there is some difficulty. The learning him with steep learning curve, right? So that is why. Let's see what's going on for future. So that is why I started this the plan, a project. Luckily, I was able to gather government funding for multi-center study, randomized base. I created a 4 randomized control trial. The first and second arms is bipolar versus the bipolar endoscope versus microscope for discectomy and stenosis. The third and fourth arm is the full endoscope versus the microscope for discectomy for spinal decompression. So all the enrollment was finished. A couple weeks ago, we published first the 1-year outcome from the first arm, the bipolar discectomy in JBJS. This is the readers of each groups. This is the project paper published a couple of years ago. In my perspective, more than 10 papers with the level 1, level 2 evidence will be coming up within 3 years. I'm gonna make it done. Endoscope decompression for spinal stenosis with spondylolisthesis as well. That's gonna be super important in the field of endoscope. So we're gonna save the patient, a lot of the patient with the stable spondy from the instrumentation, right? So let's see the takeaway from the legendary Professor Michael Meyer. He already looked the future. Microendoscope blending, step by step, convert to the scenario where the endoscope technique replace microscopic surgical technique, right? So what about the takeaway? So spine surgery gonna be moved to the endoscope for the next generation with the endoscope. Love this music. Okay. Because of time constraints, I'm gonna move to the
And I'm really glad
one
you
thing
like
more.
everything.
One thing more.
But there is one more thing.
What is the one thing more? That's gonna be 2026. Hopefully, I'm gonna stand here again, 2026. I'm gonna talk about real funny talk, spine surgery related spine surgery. I'm gonna talk about the dark side and bright side related to endoscopic spine surgery coming soon. Thank you very much.